Yeah, it comes from here and then it wraps around to the... Hey, how are you? This is Dr. Evan Osar with Integrative Movement Insider. I was just discussing with myself, the Obturator Internist. And if you have and work with female clients, of course you work with female clients that have chronic hip issues and or pelvic floor issues, then the Obturator Internist is one of those muscles that you may need to address. Welcome to this edition, and we're going to discuss the pelvic floor and your female clients, especially those clients that have chronic tightness, and many of those clients who struggle maybe with stress urinary incontinence. Stress urinary incontinence is actually a condition where, what it sounds like, women will leak when they're under stress, physical stress, not emotional stress, but maybe emotional stress as well, but more physical stress. So in coughing, sneezing, and or doing physical activity. Hello, my friends. Sue Gleason, one of our integrative movement specialists, my best friend from back home, Pete Rislow, and Mary Trella. How are you? Good to see you as well. So one of the things that we will see with a lot of our clients is, as I mentioned, female clients, especially, again, male clients have this as well, but we're focusing today on female clients, is stress urinary incontinence, or SUI. So again, this is a leakage of urine when individuals are stressing out during coughing, sneezing, laughing, and or exercising. And again, it's not a laughing matter at all. However, it's sort of an embarrassing issue, and many of our clients may be reluctant to discuss it with us. Now, one of the things I would recommend here is that you work with a pelvic floor therapist in your area so that you have someone to refer your clients to. Because again, you know, I'm a manual therapist, I'm a doctor, but I don't do internal work. So a pelvic floor therapist can do internal work. They can use a diagnostic ultrasound to look at pelvic floor function and really help your clients with pelvic floor function. However, for you and I as health and fitness professionals that don't work specifically with the pelvic floor, I just want to give you a couple things to think about as well as to evaluate in your clients that can improve the pelvic floor. And again, I can share this information with you because I work with a pelvic floor therapist that we refer to in our office. I also have another colleague online that I consult with as well that has given me a lot of great information around the pelvic floor. So I'm excited to share that information with you and tell you about an upcoming resource for those of you that work with female clients. Now, one of those muscles, as I mentioned, the Obturator Internist. Now, this is not to say this is the only muscle involved in hip issues. However, it's one of the more common muscles. So the Obturator Internist, obturator refers to this obturator foramen. So you see this opening here in the pelvis here. That's called the obturator foramen. Now there's a fascial tissue that lays over top this obturator foramen. The Obturator Internist and Externist both attach around to and or around this opening here. Well, the Obturator Internist comes around the backside of the pelvis, so it wraps around the backside of the pelvis to insert into the greatotrochanter of the femur. So it can help to externally rotate that femoral head relative to the pelvis. However, it can also contribute to moving the pelvis. When you're standing, it can contribute to moving the pelvis around the femoral head. So again, in open chain, it can move the pelvis, or when the foot's off the ground, it can move that femur relative to the pelvis, or it can move the pelvis relative to the femur. Now, a lot of our clients, when you think about clients that have a challenge with stress urinary incontinence, think about this. You know, if you know that you have the potential of leaking when you cough, sneeze, laugh, and or work out, well then think about this. You would probably tense up the pelvic floor. And there's actually a great research article I was just reading. I don't know if it was great. It was a related research article that discussed, they thought that women that had better pelvic floor function actually would have less movement of they were looking at the bladder specifically. So the bladder sitting sort of right behind your pubic bone here. The bladder would move less in individuals that had an optimal functioning pelvic floor. But what they found was that the women that actually had continence, they didn't leak when they exercised, coughed, laughed, or sneezed, they actually had more mobility of their bladder compared to matched pairs. So these were women that either had no children and or only had one children. Those same group women that actually had urinary incontinence, stress urinary incontinence, they actually had less bladder movement. So this is very interesting because, you know, one of the things that working with the pelvic floor therapist has taught us, and many of our clients have demonstrated, is that a lot of our clients that have urinary incontinence, they actually have an overactive pelvic floor. They have overactive external hip rotators like the Obturator Internist that I just described. Because think about this, if you know that you leak, you have a history of leaking, well, what are you going to do when you're under exertion? You're going to clench that pelvic floor, your pelvic floor, right? You're going to squeeze and tighten and hold it. And what the research showed was that the pelvic floor or the bladder moved less. That means they're clenching and holding more tension in the area. And that's a common reason why many of our female clients, or I should say a good portion of our female clients, may lose hip rotation. So one of the things we want to look at is hip rotation. And if we suspect that our client has an issue with their pelvic floor, which hip rotation could be a sign, doesn't mean 100% your client has an issue. I'm not suggesting that. I'm just saying it could be related to your client's. So that's a question that you may want to ask your client. And again, be tactful about how you ask your client about it. But again, that's one of the first questions we ask our clients in their medical history is, do you have a history of stress incontinence? Do you leak when you exercise or exert yourself? Because again, we want to know that because that will change their hip mobility. That will change your hip recruitment. So work with a pelvic floor therapist in your area. Find one. It's a great referral source. I mean, we refer out to our pelvic floor therapist, and when the pelvic floor therapist is done with their clients, they're happy to refer them to us because they understand how we work and that we will integrate the information that they're giving into our clients' workout program. So it's a great referral source. Now, how can you determine if your client potentially has a pelvic floor issue or not? Obviously, you'll know something from their history. If they've had traumatic childbirth, if they've had C-sections and or some pelvic floor damage or injury during childbirth or some other condition like that, that will give you sort of a clue also that you may need to look further at it or discuss it with them about this sort of issue, stress urinary incontinence. Another thing we can do is look at how our clients are breathing and their hip rotation. So let's do this together. Let's just check. Again, this is not suggesting that you and I have a pelvic floor issue, but let's just show you how we can start to incorporate some of this information about the hip rotators, because let me back up just for 1 minute. The hip rotators, like the Obturator Internist, as I mentioned, it's sitting in the obturator foramen. Well, if you think about inside the pelvis here, so if you look inside the pelvis, here's your obturator foramen here. Well, your pelvic floor muscles are attaching to the sacrum. Some of them are attaching from the sacrum and the coccyx right in front of that. So they're also fascially blending into the obturator foramen. So the fascial connections between the pelvic floor and hips are quite intimate. So when we change pelvic floor function, we're likely also changing hip rotation. And that's what we find with many of our clients. And this is the reason why I've established relationships with pelvic floor therapists, is because they can give me that direct information because they're doing palpation. They're palpating the pelvic floor in their patients. They're looking at it on diagnostic ultrasound. So it gives me a lot of information that I wouldn't have otherwise. Okay, so what we can look at, like I said, is hip rotation as well as breathing. Because what we're going to find is, let's just do this together. Put your feet about hip width apart. Put your hands on your pelvis. Check your standing pelvic or standing hip rotation. Obviously, you check it in a couple different positions. So my right side hip rotation, pretty good. Left side hip rotation, decent, because I've been working on it. Not as good as my right side. Now, the other thing we could look at also is how your client is breathing. What we found, and what pelvic floor therapists have also correlated to our findings, is a lot of our clients will not breathe down past their umbilicus. You may see a lot of belly breathing. So you may see your client doing a lot of belly breathing, but you don't see a lot of inferior breathing. So especially down around the level of the ASISs, or those anterior superior iliac spines. So you may not see breath down low. So put your fingers down here. We would check this in standing and lying down as well. Just put your fingers down in your lower abdomen. So find your ASISs. So the ASISs are these little pointy bones right here. So find those little pointy bones on yourself. Take a couple deep breaths in and see what happens where your breath goes. So breathe in again. And what's interesting, as I'm standing here, do it one more time, is I can actually feel my breath coming down to my right side. It's not coming down to my left side, my tighter hip, as easily as it's coming down to my right side. So when I jump on the table here for breathing, I'm going to focus a bit more on breathing into my left side. So you can have asymmetry, your client can have an asymmetry depending on how they're gripping, how they're overactivating certain muscles and or stopping themselves from breathing from a number of reasons, whether it's a muscular contraction and they're not allowing themselves to breathe down into that area. Maybe your client has had scar tissue or surgery in scar tissue. We've had lots of clients that have had bowel obstructions from scar tissue after C-sections, hysterectomies and other abdominal surgeries. So it can also be a relationship to that. In a lot of your clients' cases, it's just they're overactivating muscles, in their abdominal region, their rectors, their hip rotators, as we discussed, so they're not able to breathe down into that area. So let's go into, so you've checked your hip rotation, you've checked your breathing, let's go into a very simple strategy. Again, we'll do about 5 breaths. So what we're going to do is lie on our back, and we're going to do a very simple bent knee fallout. The reason why we'll use a bent knee fallout, and we will have done myofascial release. So basically what you're going to do is you're going to do some myofascial release right behind the hip joint. So basically where that femoral head comes into the acetabulum, there's a space right between the ischial tuberosity here and the greater trochanter. So we'll use some kind of myofascial release tool, a lacrosse ball in the supine position to do some myofascial release on the back side of the hip, especially for those clients that tend to be hip grippers, like many of our female clients are, especially ones that have a history of stress urinary incontinence. So we'll first do that, but let's do it without any myofascial release, just to show you how powerful this strategy can be. So we're going to lie on our back, support the head and neck, keep the spine in a your client's relative neutral position. And what I mean by that is, like, there's not this sort of perfect neutral position for everyone. It's just their most neutral position. And actually some of the research I've looked at also, this is why it's important to look at the research, is that the best way to activate, or I should say the position that seems to activate the pelvic floor and even the transversus abdominis is not posterior pelvic tilt. It's actually slightly more neutral, which is slightly more towards an anterior pelvic tilt and lumbar lordosis. And I'm not saying force your client into that position, just don't force them into posterior pelvic tilt. So get them to their most neutral position, bent knee position, have them do a couple pelvic tilts forward and back, get them to the most neutral relaxed position. Hands go below that anterior superior iliac spine, those ASISs. Now focus your breath down towards that direction. Let's go 5 breaths. We're going to breathe in and out through the nose. Breathe in through the nose. Send the breath all the way down to your fingers. Breathe out and relax. Keep the abdominal muscles relaxed. Even relax the hip muscles. Do another breath and relax. Now the next 3 breaths, what I want you to do is focus on letting your knees fall out gently and then breathing in to bring the knees back together. Breathe in, breathe out, let the knees fall apart. Breathe in to bring them back together. It's almost as if you want to feel as if you're rotating the hip, the ball in the socket. So you want to make it as effortless as possible. Okay? So we'll do 3 more breaths here. So breathe in, breathe out, bring your knees back together. Breathe in, let your knees fall apart. Breathe out, bring your knees back together. Just do 2 more. Breathe in and breathe out. And you can also reverse it. You can breathe in here and breathe out to relax your legs apart. Breathe in to bring them back together. And basically what you're doing is just teaching the individual just to allow the hip muscles to relax and allow that hip to move within the socket without that gripping. And then you're also focusing the breath down towards the pelvis. Great and super effective way to release hip tension. Now, we've done about 5 breaths. Go back and let's recheck our hip rotation. So put the feet back underneath the pelvis, rotate to the right. That actually feels easier. That was already easy, but actually feels easier. Left side actually feels much easier now as well. So again, you can just it's a super easy way. We just did like 5 breaths and it was able to relax those hip rotators. Now we have to incorporate that into functional activity. Now, one of the things we want to think about with the pelvic floor and breathing is when you breathe in and the pelvic floor and diaphragm drop down. As you breathe out, the diaphragm moves back up, the pelvic floor also lifts. The pelvic floor is actually going through a concentric contraction because it needs to lift the organs back up as you breathe out. So it's going through more of an active contraction. Many of us have learned Kegels and that can be appropriate, but we only recommend Kegels if our pelvic floor therapist that we refer to recommends them. And I can tell you very rarely does our pelvic floor therapist ever recommend somebody to do a Kegel by itself. Just hold the pelvic floor and squeeze and hold it. Very rarely. It's really a coordination. It's most oftenly a coordination between breathing and then a slight lift. So let's just do this a few times. So let's use a squat pattern, for example, as an example. So what we're going to do is we're going to breathe in. So again, breathe in, get the breath down low. Breathe in, get the breath down low. And then as you breathe out, visualize lifting the pelvic floor up as you squat down. So again, we're going to breathe in, pelvic floor drops down, diaphragm drops down, breathe out. Gently lift that pelvic floor as you're actually going through your eccentric contraction. So that way you're lengthening the hip rotators as the pelvic floor is actually moving back up, okay? Or moving up, contracting to move the organs back up. So breathe in to come up, breathe out as you lower down. Do two more. Breathe in to come up, breathe out to lower down. Go through the eccentric contraction of the glutes. Breathe in to come back up. Let's do the last one. Breathe out. Pelvic floor is lifting as you gently squat down, and then breathe in to come back up. Okay? Now, you can just recheck your hip range of motion. That's even, if anything, probably a little bit easier. Just more freedom to move the pelvis around the femoral heads. And that's really the key to improving and maintaining hip mobility, is to coordinate that movement of the diaphragm and pelvic floor, your breath, along with those hip rotators, and not over grip or over contract or over squeeze those hip rotators in functional exercises. And obviously you need to train your clients at a higher level, but this is a great way to help your client reset and keep coming back towards or to a more optimal position and relaxation after they do an intense set. So you could do an intense set of maybe a deadlift exercise or a squat exercise, a loaded squat exercise, or a lateral lunge, a step up, and then come back, just do a few easy repetitions of a relaxation to let those hip muscles go, to start to retrain those hip muscles to function more appropriately, to coordinate with breath, coordinate with the pelvic floor, and you will really start to notice that your clients will be like, my hips seem less tight overall. This is also a great strategy to use during the day. If your clients are sitting and they often get like hip discomfort or low back discomfort with sitting, have them stand up, just do a couple squats with some breathing. It's a great way to mobilize the hip, reorient their alignment, and to let go of some chronic restrictions. So this is Dr. Evan Osar with Integrative Movement Insider. I hope you enjoyed that video. I hope it helped demonstrate some of the importance of coordinating the hip rotators with breath, with the pelvic floor, and into functional exercise as well. And this is going to be our brand new topic of Two Anatomy Geeks, the series that I do with my colleague and friend Jill Leary. We started this series actually 2 years ago. Actually, 2 years ago, I think it's May. 2 years ago, April or May, we started this series during the first lockdowns, like way back in 2020. And it's been an amazing community, an amazing series. This brand new series that we have coming up in May is discussing female anatomy and female specific training conditions. We're going to address in week 1, May 7th, I believe it is, Saturday, May 7th, we're discussing the pelvic floor, how to assess and use simple assessments like this if you're not a pelvic floor therapist, which I'm not. How to assess the hip and use breath in the hip to improve pelvic floor function. In week 2, we're going to have our guest geek jump in here, and we're going to discuss issues associated with pregnancy and surgery and scar tissue and some of the things that aren't frequently talked about around the abdomen, pelvic floor, and hip issue or area. And then in week 3, we're going to discuss more bone density, because so many of our older clients, our female clients, even I should say older, my age, in the 50s, are already developing osteopenia, osteoporosis. So we're going to address how do we train optimally for bone density. And I'm going to have a couple guests come in for that as well. I'm going to have my personal nutritionist come in and discuss what she teaches her clients to do for bone density from a natural standpoint. So some of these supplements and dietary recommendations and supplements that she uses for her clients from a more natural standpoint. And then we'll talk obviously exercise assessment and exercise around bone density. So that way you have a strategy to really address some of these common issues: pelvic floor, pregnancy. I'm going to have my friend and colleague Sarah Fisher come in and discuss, what it was like after she had a C-section and what she trains in herself and her female clients as well. So Yeah, and then Phoebe will probably jump in here and and let herself be known as well. So we look forward to seeing you in this brand new series of Two Anatomy Geeks. Starts on May 7th. I'll put the link next to this video here on Facebook. I'm not sure where it is if you're watching it on YouTube, but thank you again for joining us. We'd love to have you as part of this wonderful community, Two Anatomy Geeks. It's really an amazing community of like-minded individuals who are there just to support each other. We're not there to challenge you. We're not there to, say what you're doing is wrong. It's just like, hey, let's work together and let's figure out like what's the best strategy for addressing issues like, addressing the pelvic floor, addressing women during pregnancy, after pregnancy, and women before and after surgery as well, and women that are dealing with osteopenia and osteoporosis. So we'd love to have you join us. Thanks so much for watching. Thanks for being part of our community. If we can do anything to support you in your journey, please reach out and let us know. This is Dr. Evan Osar with Integrative Movement Insider. Make it a great day, and we'll talk to you soon. Take care.